Well, thank you. Good morning. So my name is Steen Hanson, and I'm a medical doctor all the way from Denmark. I'd like to say thank you for having the opportunity to make this presentation today on how to use structured light to make an accurate estimation of an instrument position and the relation to the surgical surface. So, perfect. So these are my disclosures. So I'm a co-founder and a board member at a small startup called 3D Integrated. Further, I'm a co-inventor of some of these technologies that we're going to present. And it has to be said that 3D Integrated is the owner of intellectual property rights related to this presentation. So for a lot of time, people have been discussing the importance of training of surgeons, the learning curve related to different procedures, surgical skills and surgical performance. Recently, there was a study in the New England Journal of Medicine showing that when they assessed surgical performance as how the instruments were maneuvered during surgery, they were able to sort of see that the lowest performing quartile compared to the highest performing quartile performed a lot better on surgical outcomes, such as surgical complications, readmissions, and operating time. The problem is right now we do not have an objective way to measure these parameters. So what we would need was data that would allow benchmarking of surgical skills and performance. So what you need to do is sort of track the position and orientation of the instrument. You can do that right now using kinematics in robotics, magnetic tracking, or optical tracking. But doing that in an isolation is sort of, you can do an analogy to an airplane where the pilot is flying in foggy weather. So he has the position of the flight, but no idea where the ground is or the landing field he's about to approach. So basically what you want to combine this with is information on the surgical surface, such as a 3D topography. And coming back to that analogy, what you want to have is information on the landing field. Where is it? And importantly, are there any obstacles in your relation that you want to avoid so you can make a safe landing for you and your patients? So what we do is that we have positioned a projector on a surgical instrument that projects a structured pattern in the surgical field. And as you can see in the middle picture here, that image is sort of acquired using a standard laparoscope. That image, we can extract the data from this pattern and make the positioning of the instrument together with the topography of the surgical surface. And this allows for the first combined data set where you have a combination of the instrument relating to the surgical surface all the time. So you can see there is an image from the laparoscope, and then that image is sort of put inside the computer, and then we get a data output as shown in the box to the left. And so the figure shows a 3D reconstruction and the instrument position and orientation in relation to the surface. In addition, we get metrics such as continuous distances to the surface, pitch and orientation of the instrument. We get velocities such as acceleration, deceleration patterns, tissue contact, and importantly, how long was the duration of each tissue contact. And we can do that. So right now we have preliminary results, but we can do that with very accurately with a point-wise accuracy of less than 1 millimeter at present. And we can do instrument tissue distance accuracy within 1 millimeter at present. We expect that to be further accurate in a short while. So this allows for novel and relevant metrics that can be used for benchmarking surgical performance in each operation. So now I saw an in vivo metric data from preliminary results, and it actually shows the light distance from the projector and from the tool tip of the instrument. And so these are distances, but we can also estimate velocities. In this image, we have filtered the pattern away so it's not in the way of the surgeon who is about to operate. And on the right, you have the image from the laparoscope with an overlay of these distances continuously. So the way we want to use this data is that we want to learn from master surgeons and learn what are their moving patterns and make that data available to younger or more unroutine surgeons. So what you can do is make a performance benchmarking of each surgeon. In that way, we are able to provide individual feedback. Let's say you're a young physician, and you have some movements that are not optimal. Well, we will be able to tell that to each surgeon each time they operate when correlating these data with information from experienced surgeons. That can lead to new sort of certification helpful for the surgeon himself. He knows exactly what kind of level he's at in different procedures. And it's also the benefit for hospitals and patients, as they know, well, the surgeon is at a certain level in comparison to masters within the field. Finally, we believe, based on the New England Journal study, that this might improve patient safety. Finally, I want to look at, well, what could the value of these things be? Well, from the learnings we have from bariatric surgery, where there was a comparison of lowest performing quartile surgeons with highest performing, there was a lot more complications, more readmissions, more reoperations, and a higher operation time. So considering the surgical complications alone, and extrapolating those results to like costs related to complications on average, the potential gain or cost savings can be quite substantial, meaning that these could benefit the surgeon, patients, but actually also hospitals. Thank you.